Moving on to our next session. Our next session will be on arthroneural symptoms in diabetes. And the first topic is on optimization of neuromuscular health. It's my pleasure to call upon the moderator for this session, Dr. Sunil Mishra sir. The experts will be Dr. Rajiv Khanna, Dr. Shehzada Salim and Dr. Shweta Singh. Dr. Shehzada won't be joining us for this session. I call upon the experts, Dr. Rajiv Khanna and Dr. Shweta Singh.
Thank you, the organizer, and thank you, Dr. Shaptarishi and its team for this wonderful meeting. So, I'll be talking something different from what we do in day to day. That is the neuromuscular health in the people with diabetes. So, we keep seeing patients with diabetes with various complaints, and most of the time they are not concerned about the glycemic control, but rather for those symptoms for which we really pay attention and really rarely do too much about that. So in that aspect, our first discussion is on the neuromuscular health, and Dr. Rajiv and Dr. Shweta will enlighten us about the neuromuscular health in the people with the diabetes, how do we see and how we need to help them. So first I would like to ask Dr. Rajiv is that the spectrum of the neuromuscular disorder in the diabetes and what we understand by this thing and what we should know about the neuromuscular health, because this is something upcoming and more than one complication. The muscular complication of diabetes is one of the latest evolving complication which is being better understood now.
Should I start?
Yeah.
Dr. Sunil, I make your question neuromuscular to more simple by dividing this word into two parts, neuro and muscle. So once we divide this part, we will become more wiser to understand this topic, because if you see at the various books, there is no chapter that define the optimization of neuromuscular health in diabetes. I studied there is a neuroskeletal health and connective tissue disorder, but there is no chapter on neuromuscular health. So I divide the topic into nerve and muscle. So we all know that diabetic neuropathy is one of the most common complications of diabetes. It affects around about 90% of the diabetic population. It is also one of the most common complication neuropathy among all the neuropathies. So we know the different forms of diabetic neuropathy like acute, chronic, focal, multifocal, proximal, distal, small fiber, large fiber neuropathy and TRAM neuropathy. There are different spectrum of the various neuropathy occurring in the type 2 diabetes. Also, another neuropathy is autonomic neuropathies. So these are the neuropathy spectrum of neuropathies in diabetic population. We'll look at the muscle part. So definitely, if we go through the effect of diabetes on muscle, we have seen that there is in chronic diabetic patient, uncontrolled diabetic patient, there is a loss of muscle mass. Then there is a muscle power decrease, muscle endurance, सहन शक्ति of muscle is decreased, composition of muscle fiber is decreased. So both these effect, that is neuromuscular effect on the diabetic patient, it will lead into diabetic foot ulcer, may lead to frequent fall, frequent hospitalization, increased morbidity and mortality. So in this way, it will affect the morbidity and mortality of the patient.
Thank you, Dr. Rajiv. So I will ask Dr. Shweta regarding the connection which Dr. Rajiv was talking about. There is a connection between the nerve and muscle. So what is the pathophysiology behind this new type of the complication, the neuromuscular complication?
Actually the pathophysiology is multifactorial.
I have your slides.
Yeah, please, sir. Yeah. So please. It's a beautiful slide, and it very nicely captures all the component of the pathophysiology.
How to advance slide?
So hyperglycemia or persistent hyperglycemia leads to a number of pathways that get activated.
Next.
Right.
This one?
Yes, sir.
Yeah. Please stick.
So it's very important to understand, apart from high glucose level or persistent hyperglycemia, it is also the increase in LDL levels or increase in free fatty acids in a diabetic patient that is leading to the nerve injury. nerve or muscle injury for that matter. So both the nerve and muscle injury are because of the oxidative damage, and there are the number of pathways that get activated. That is the polyol, because of the hyperglycemia, polyol and hexosamine pathway get activated, and because of this, there is the byproducts of these pathways, increased reactive oxygen species, and that leads to endoplasmic reticulum stress and DNA damage. So it is occurring at the level of the DNA, it's the nuclear damage that's occurring in these diabetic patients. Apart from that, high glucose level means increase in glycolysis, and increase in glycolysis means increase in acetyl-CoA. And acetyl-CoA usually gets transported to the electron transport chain, and but at some point of time, there is an overload with the increase in acetyl-CoA, and that gets changed into acyl-carnitine, which again is a very toxic substance for the neurons, especially the dorsal root neurons and the Schwann cells. So basically, diabetic neuropathy, the most common variant of the diabetic neuropathy that we are talking about, that we already see, is the painful diabetic neuropathy, or the small fiber neuropathy that affects the small fibers and is also responsible for the dysautonomia or autonomic nervous system neuropathy in these patients. And this occurs as early as, let's say, in type 2 diabetic, it occurs as early as in like the first year of the diabetes, and in type 1 diabetic it occurs as soon as the second year of the diabetes. And this is occurring usually at the subclinical level, and these subclinical damage is because of the damage of the dorsal root ganglions and the Schwann cells, which are unable to support the axons, right? And because of this increase in toxic substances like acyl-carnitine, and there is increase in oxidative phosphorylation, and finally this is actually also leading to the mitochondrial damage. So apoptosis occurs because of all these activation of all these processes. And not only this, the LDL that's high in high LDL and free fatty acids in diabetic patients, that also lead to oxidized LDL, and the free fatty acids again is bypasses and goes over and increases acetyl-CoA, and again that leads to further on the mitochondrial damage. And not only this, just please next slide, sir.
This one?
This one.
Yeah.
So it beautifully shows again how the axons are affected. So axons have Schwann cells, which is able to sustain the axons and give nutrition to the axons. Axons are a long extension of the neuron, and they need support in terms of nutrition, and otherwise they need myelination. And Schwann cells get affected because of these activation of RAS, oxidative phosphorylation, DNA damage. There is impairment of the cytoskeletal structure. There is impairment of the transcription factors, and mRNA is also involved. So it's actually at a multiple levels. It's not at a single level that the nerve is getting affected. Initially it was thought it was only the axon. Now we know it is also the neuron. So both of the things are being damaged. And because of this damage, there is also upregulation of the channels. It's both the sodium channel and the calcium channel, and they have further on subunits. And some of the subunits, it's actually written over there, 1.8, it gets, the expression is increased. This leads to more fast conduction of the pain pathways. This faster conduction of the pain pathways, it sensitizes the whole of the pathway till the somatosensory cortex, where the pain is being perceived by the brain. This again an temporal perception of the pain sensitizes the central nervous system also. So finally pain is felt more also. It then occurs as brushstroke allodynia, and the patient is feeling pain even on a non-noxious stimulus. So this is more or less the diabetic neuropathy, and especially the pain-filled neuropathy, how it occurs and how it affects the nervous system. And nervous system is not only affected at the endings, it is also affected at the central level.
Right. Thank you. So I think this is something we need to understand more, and we need to give more attention towards. It's not merely the symptoms. So the damages keep happening both at the end of the nerves as well as in the muscle, and that will also definitely create a problem.
So this is again recapitulation of the same thing, that there is microangiopathy, and because of that vasculopathy is there, the nerve fibers are not getting the proper, capillary density is less. There is ischemia to the nerves, there is hyperglycemia related damage. So this is just a recapitulation of the previous two slides. And understanding the pathophysiology is important, because this is how we try to create the management system, or this is how we understand how to manage these patients. So therefore the slides are very self-explanatory, and because when we talk about the management of these patients, then these pathways would come along in our memory, and and finding the right strategy and the therapeutic approach.
So something about Dr. Raji was speaking about the sarcopenia. So if you look at these two arms of the patient, so virtually will look probably similar, but we look at the people with the diabetes, how the muscle becomes weak. They will not any change in the weight, but over the time the muscle getting weaker and weaker, and this is known as the sarcopenia. Now it is one of the complication of the diabetes which is upcoming, because it has not been well addressed. So how to measure the sarcopenia, how to look for the sarcopenia? A is visual our thing, but we may miss many of the Indian people. Asians will have more fat mass, and the lean muscle mass will be less. So there you can do it by different method, like anthropometry, which has simplicity and low cost, or bioelectric impedance, and then DEXA, CT, MRI, and the ultrasound. So some of them are a little more complex, more validity, and some of them are very simple, but the reproducibility and the research application is practically low. The two of the things like DEXA and bioelectric impedance are more often used. CT, MRI, because of the cost and the exposure, are less often used. So how do we diagnose? So there are the studies are coming up how to diagnose the sarcopenia. In one of our study from a hospital in people with the type 2 diabetes, we enrolled 94 individuals with the type 2 diabetes and matched 64 control. And if you look at just by doing the bioelectric impedance and the hand grip measurement of the muscle power, the 50% of the people with the male individual with type 2 diabetes and 44 ladies with type 2 diabetes have had the sarcopenia. So you do the hand grip, then you do the gait speed is also one of the measurement for how the gait. If there is no issue with the low hand grip and the gait is usual, no sarcopenia. But if there is low grip strength and the low usual gait speed, then you need to do the skeletal muscle mass. You may do it by the DEXA, or you may do it by impedance, which is a simple machine in most of the hospital now having. And if the DEXA and the BIA, if it is less than 7 in men and less than 5.4 in the ladies, it is the low and the low muscle mass, and if it is normal, there is no sarcopenia. So this is how we diagnose sarcopenia. Now the question arises that I direct this question to Dr. Rajiv. What is the relevance of sarcopenia in the people with the diabetes? We know that they are having less mass, Indians have less mass, so how you relate it with other complication and how to address it?
Dr. Sunil, as you said that this sarcopenia is a degenerative disorder occur after the age of 40, and the prevalence is I think 8% per decade up to 70 years. So in diabetes there is also it is affect the muscle mass of the muscle of the patient. So definitely, so there is acceleration of the sarcopenia in a patient of diabetes. So this can occur. So it has been from the various studies and found that in diabetes up to 30% of the patient have sarcopenia. As you said, then Asian population have more sarcopenia because our fat cell are fatter than rest of the world. So that could be the reason. And various association of this sarcopenia in diabetes depend upon the duration of the diabetes, BMI of a person. That BMI is low, sarcopenia is high, and even this age, older the age, more the sarcopenia, duration of the diabetes, then other association of other complication like microvascular and macrovascular retinopathy. Even it has been seen that the patient having more than 2 anti-diabetic drugs, sarcopenia is more. So these are the various association of sarcopenia and diabetes.
Thank you.
Even it is nowadays it is said that this sarcopenia is the third complication of diabetes after micro and macrovascular complication. It is regarded as the third complication of diabetes.
Yes, thank you. So, in our day-to-day practice, Dr. Shweta, of course, you might be seeing little later than, but we do see in our day-to-day practice that painful diabetic neuropathy. So, there are patients who will come, they are less bothered about their retinopathy, their nephropathy, or even the glycemic control, but they are presenting complaint until unless we settle that problem, they will not going to stick to me or they are not going to stick to my colleague until unless we settle it down. So how should we approach patient with the painful neuropathy in diabetes?
Right. Painful neuropathy is one of the most troubling symptoms in a diabetic patient, and it decreases their quality of life tremendously.
Yes.
So if pain is a bad sensation, and apart from it's a noxious sensation. So usually the brain is always trying to classify everything into pleasurable, non-pleasurable. So noxious, and especially if a simple touch is perceived as a noxious stimulant, that becomes very unbearable for a person to live with. And many a times, again, this pain, what I would say before I go on to the, further on, that this pain should also be differentiated with other pains in a diabetic patient. The patient might also be having an arthropathy, they might also be having an radiculopathy. So those things should also be segregated. It could also be a simple plantar fasciitis, which the patient might be complaining, and we might be thinking it is painful diabetic neuropathy. Painful diabetic neuropathy is a small fiber neuropathy. Many times it is difficult to prove. NCVs are normal. The electrodiagnostics, the usual approach is normal, and many times the touch is also preserved. So it is important to understand first of all what we are dealing with, so that we are able to give the proper management. If it is plantar fasciitis, we treat the plantar fasciitis. If it is radicular pain, many times because of the poor pain perception in diabetics, many times radicular pain can also present with only a 1 foot pain only in the sole. So that would so differentiating feature would again be asymmetry. That would lead to us suspecting whether it is a radiculopathy rather than a painful neuropathy. Again, approaching means you also try to diagnose it with the appropriate instruments. Either you do a clinical examination, take a history when the pain is more, and if it is associated with restlessness at night, and what kind of diabetic control is there, what are the associated risk factors in that person, and whether there is any loss to touch, pressure, pain, and the thermal sensation. So usually what would these patients would have is that the vibration might still be preserved, but the heat threshold and the cold threshold would be impaired. So the temperature and the pinprick would be more useful in these patients. So that would be impaired, and that would help us diagnose whether this patient actually has painful neuropathy. Then understanding the patients, how troublesome are the symptoms and what are the comorbidities, whether the patient also has psychological overlay to the pain. So that would help us decide the further management in these patients. What kind of glycemic control is this patient having? So whether the HbA1c is under control, or if it is there is a persistent hyperglycemia. So those things would also help us in managing these patients. In diagnostics, usually the NCVs would be normal. The large fibers are usually preserved. The nerve conductions usually detect only the large fibers. We can do sympathetic skin responses. Most of the laboratories have that. Those can be done. And apart from that, there are various things that have been described, but most of the time these things like QST and QSART, these are not practical and they are not easily available. So there is something called pseudoscan that's coming up. That's a 5 minutes test. Actually, our hospital is trying to procure that. So it again is able to detect the small fiber loss. And it actually is dependent on the skin conductance, because with the help of it detects the sweat and how the electrochemical skin conductance because of the sweat. So that those things can be used to detect whether the small fiber neuropathy is there. Again, management would coming to the management. So managing hyperglycemia again is the first and the foremost thing in these patients. Again, symptomatic relief would also be needed, and for that we can use antidepressants, gabapentinoids or antiepileptics. So the usual anti-epileptics that we use, even though they are on the second line, I'll first of all go on the first line. The first line is different in different countries and the guidelines, but usual that we use over here in India is TCAs and SNRIs. So TCAs, what is easily available is amitriptyline and nortriptyline, and SNRIs that are available with us are usually venlafaxine and duloxetine. Duloxetine is commonly used, and long-term duloxetine efficacy is quite good. Apart from the cost factor, which is more on duloxetine. Then gabapentinoids are very commonly used, pregabalin and gabapentin. They are very commonly used and they are pretty effective. So this is usually a combination of these medicines like a gabapentinoids, and if there is a psychological overlay, TCA and SNRI, either of one of these would be used to help them relieve their pain. Finally, opioids may be used in a rescue condition. So if the pain is too much, not patient is not feeling better on very high doses of either gabapentinoids or TCAs or SNRIs, that we can use on the SOS basis. The daily or routine usage should not be recommended. Is not recommended. Finally, local application in form of local lidocaine gels, gabapen gels, and now gabapen gels are easily available, and also capsaicin ointments, those can be used. Apart from that, again, few antioxidants like alpha lipoic acid can be used, and aldose reductase inhibitors are also can be used. So what the only palilistat has been approved, that also has been shown to kind of at least halt the progression of neuropathy. So all of these things are the mainstay in managing these patients.
I will come to one slide last, just for the remembrance of everyone, including us. So again, I will direct one question, then I will come to Dr. Raji. Regarding the diagnosis of diabetic neuropathy, how to plan the investigation? Because when it comes to us, we usually based on the symptom, so we do not go for it. By the time they reach neurologist, all of them do the electrodiagnostic test. So
Right.
how to plan which investigation? The B12 should be done in every individual. So of course we do the basic biochemistry, including kidney, liver, and everything, glycemic control.
Right.
But regarding some biochemical and electrodiagnostic, and how to plan for those things.
So again, what I would say, it is the first and the foremost, being a neurologist, I would say clinical examination is very important.
Yes.
In neurology is one branch where you have to, actually examine the patient and evaluate the sensations in that patient, evaluate look at the power of that patient, check the reflexes, look if there is any asymmetry, what kind of neuropathy is the patient having. Again, in terms of sensation, touch, pinprick, vibration, position, all of those should be investigated and evaluated. That would give us a clue many a times, and for example, and also this would also help us rule out other type of neuropathies in this patient. For example, mononeuropathies, leprosy also can present many a times as with pain or sensory symptoms, positive sensory symptoms. So again, the first is clinical examination, and only after clinical examination electrodiagnostics should be ordered. So electrodiagnostic, the first is nerve conduction study that evaluates large fiber. SSR can be ordered along with that. Most of the machines are they have SSR facility. Most of the NCV machines, good NCV machines. So the SSR all tell the decrease in the SSR, sympathetic skin response, tells that the patient is probably having small fiber neuropathy. Again, I'll just stick to the practical there, because there are a number of things that has been described, but we don't use all of this. And finally, for example, if we are very kind of bent on that we need to understand this and we need to document the small fiber neuropathy, skin biopsy can be taken. So intraepidermal nerve fiber density can be seen in those patients. If we and again, small fiber neuropathy in a diabetic patients again means that it might be because of diabetes, but again we should keep in mind that the other factors that it should not be drug induced, it should not be because of some other cause. So we should keep our differential list, and we should also exclude the other causes, be it the small fiber, be it the large fiber neuropathy. So that list should always be excluded. Just having diabetes does not mean it is a diabetic neuropathy. So having a differential list in the mind and excluding those things are also very important.
So I will come to the same question, to the next question in the line of that. So Dr. Rajiv, we keep seeing patients in our routine practice, they complain of neuropathy with the diabetes. So how common is the non-diabetic neuropathy? Because some of the non-diabetic neuropathy, which of course after you, Shweta, will because they are treatable. They are immunomodulator and the pulse steroid therapy does change. So how
Yeah.
common and how to suspect the non-diabetic neuropathy?
It is a very good question. Most commonly asked in the exam also. Every neuropathic symptom in diabetes is not a diabetic neuropathy. So there are some condition when we suspect patient is not having diabetic neuropathy. So these are when there are these condition when there is inappropriately increased deterioration of the neuropathy, involvement of the upper limb or involvement of the motor power. Then patient may have mononeuropathies, patient have cranial neuropathy. There is a rapid deterioration, and even patient have normal glycemia, and with normal glycemia there is deterioration neuropathic symptom. So these are even there is family history of neuropathy, genetic neuropathy. So these are the various conditions when we suspect the non-diabetic neuropathy. And there is a common MD standing teaching is we should know all the causes of neuropathy: A, B, C, D, E, F, G, H, I. That is A for A, vitamin, C, alcohol and autoimmune; B for blood dyscrasia; C for connective tissue disorder, collagen vascular disorder and congenital; D for drugs and diabetes; E for endocrinology, environment; F for familial; G for genetic; H for hereditary; I for inflammatory, infiltrative and idiopathic. So we should know all these A, B, C, D.
This one I didn't know in my MD.
This is Dr. Luthra is there. Dr. Datta used to teach us during my MD in Amritsar.
Thank you. So wonderful. So we should suspect about the non-diabetic.
And one thing,
Yeah.
so these are the conditions when we should refer the patient to neurologist.
Yes. So
But in real world, we refer the patient only when patient come to us frequently. That's why मेरी pain नहीं ठीक हो रही, मेरी pain नहीं ठीक हो रही. After 3 or 4 visits, we said all the diabetology endocrinology refer the patient to neurologist. और डॉक्टर साहब को जाओ को टेस्ट करेंगे, because it is a very irritating neuropathy is irritating complication, irritate the doctor as well as patient. So we refer only in that condition to the neurologist.
goes very late. So, Dr. Shweta, sometimes patient keep hanging with us some of the treatable cause of neuropathy. And I have seen itself in a hospital. So when those people are seen by neurologists, so with, for CIDP and other region, so how to suspect those neuropathies and how we can catch hold early those patients and help them better? So treatable cause
CIDP,
of
again, the patient might or might not have a good or bad glycemic control. It would be irrelevant, number one. Number two, it would be more proximal. Distal would be preserved. That's a big clue. And also, basically, the progression would be a little on the rapider side. So it would be more kind of a subacute to kind of over a period of few weeks to months. So the patient would suddenly be going down. So that would help us differentiate that yes, it is not like a typical, it's not acting like a typical diabetic neuropathy, because most of the diabetes associated neuropathy would present with sensory symptoms first. The patient would, this time the patient would come with difficulty in walking, progressive difficulty in climbing stairs or getting up from squatting or sitting position. So those things should alert us that probably it is not the simple common variant diabetic neuropathy that we are dealing with, and maybe we should at least do a conductions. Conductions would definitely show us demyelination. When the demyelination is seen over there, we should definitely further on investigate the patient with an autoimmune profile and with CSF, with or without CSF, to look at the CSF protein levels. So that should help us to sort it out. So it's more of a proximal neuropathy. Again, proximal asymmetrical neuropathies can also be there, brachial plexopathies can also be there, or lumbosacral plexopathies can also be there. Those are usually asymmetrical. Again, pain is a common symptom in those plexopathies. Those should also, the pain, the foremost complaint of pain, development followed by development of the weakness, this should also alert that this is not a common variant type of neuropathy. So lastly, again, I would like to say autonomic neuropathy should not be missed. Neuropathy can come in a hidden way. It can come as gastroparesis. It can come with arrhythmias. So we should not, it can come as syncopes. So it can come with somebody having blackouts. So it can also come with increased or decreased sweating or constipation or diarrhea. So those things should alert us that probably the patient might be having autonomic neuropathy.
So Rajiv, again, Dr. Shweta started the autonomic neuropathy. What may be other presentation, because sometimes we do miss those autonomic neuropathy, what may be the other presentation in different organs?
I think Dr. Shweta enumerated one other presentation, 2 or 3 times patient come with retrograde ejaculation.
Right.
This is one of the most important complete that can be diagnosed semen in sperm in the urine after coitus. This is another one of the common complication autonomic
Genitourinary.
yeah. So rest, I think she even during operation there is increased pressure sport, there is a hypothermia during intraoperative. So these are the another presentation of autonomic neuropathy, I think. Rest hyperhidrosis.
Right. So we come to this one slide. So definitely you will take your opinion. So treatment of the painful neuropathy. So when we treat the painful neuropathy, so we, as you told about, exclude the other causes, because it's not always because of the diabetes. We rule out A, B, C, D, E, F, G, H, which and uremia and simple measure and sit and explain. And then while the choosing drug, unlike other symptoms, so you have a specific drug. So choosing the drug means which drug will benefit more for which kind of the patient is again a very your experience and something which can help. Like if a patient comes with a burning pain, so tricyclic antidepressant and anticonvulsant and duloxetine, and then patient comes with lancinating pain, TCA, anticonvulsant and duloxetine. Other symptom like as you talked about allodynia, so something like plastic film, leg girdle, and at night. Restless leg syndrome is common thing, which of course many a time missed. So you may use pramipexole or ropinirole. I don't
Yes,
think
sir. DA agonists are
so
used.
we'll take all your views on all these things, and then of course many times patient comes with the cramps. So first you and then Rajiv about these 3-4 the various presentation of the neuropathy and other symptoms. Yeah.
So yes.
From burning, we can start from burning.
So burning pain, again, these are all positive symptoms, and what we are trying to do is we are just trying to decrease the hyperexcitability of the neurons and axons.
Right.
So, and we are doing it with gabapentin, TCAs, and again duloxetine and carbamazepine, which even though it is less effective, it also blocks the hyperexcitability. So what I would do, and while choosing a patient, is, for example, he or she is an elderly, so I would start the patient on duloxetine. I have seen in elderly patients, this is like a personal experience, that the giddiness associated with that we see with the ataxia, or giddiness that we see with in elderly patients with pregabalin or gabapentin is not usually seen in duloxetine. Usually the elderly patients respond very nicely to duloxetine, and they might have some psychosomatic overlay to these pain syndromes, also pain symptoms also. So again, because what recommendation says, so for a pain relief, for example, they recommendations or the guidelines is very high doses, and Indian patients do not tolerate those high doses. So lowest possible dose, starting with a pregabalin or a gabapentin, followed by addition of a tricyclic or a SNRI. So this is what I follow. Again, if the person is not tolerating gabapentinoids, switch over and go on to SNRI or TCS, basically add on or switch over. And thirdly, if they are not tolerating either one of these, or they are not responding well to the appropriate or optimal doses, go on to the anticonvulsants. Anticonvulsants are carbamazepine and to a lesser extent lamotrigine and topiramate, but those are not very effective, frankly. Then these are the mainly, and again, if the patient has more of a RLS, the RLS would present with more of a discomfort, or especially at the bedtime, or while the person is resting. For example, they would say, I just sit down, कि मैं तो बैठा था और उस समय मेरे को प्रॉब्लम शुरू हो जाती है, शाम को शुरू होती है. So there is definite diurnal variation in the symptoms. Then we may add pramipexole or ropa, or DA agonist at the right, starting with again the lowest dose 0.25 in the evening, 3 to 4 hours before bedtime. And again, correction for hypocalcemia, looking at the ferritin levels is also important. Again, uremia can also lead to RLS type of a symptoms. Those should also be attended to. Just now I had a patient, people actually, I saw a prescription and there were inadequate doses of all the 3 medicines. So first of all, optimize the doses, try monotherapy, then try combination, then find out if there is something else to the picture. If RLS is there, just give DA agonist. Look at whether, for example, if the diabetic patient has a kidney problem, they might be anemic. If there are iron levels are low, correct that. If the calcium levels are low, correct that. If there is some other inciting agent or drug that is probably hurting the nerves, metronidazole or something because of some acute ongoing infection, please take care of that or change the antibiotic. So this is my approach to a patient.
I am agree with Dr. Sweta, but I want to tell you the non-pharmacological approach is इशरते कतरा है दरिया में फना हो जाना, दर्द का हद से गुजरना है दवा हो जाना.
Good.
Right.
So, I think I've been told by organizer that we have overshoot it. So, yeah, sir, please. We'll take one question.
This is not exactly exact question. You all are neuromuscular specialist people sitting here. Role of massage, because any pain anywhere, and if you start massaging that person, it is always pain is for some time it goes off. Its mechanics and its effect. Can you explain, please?
So basically, if you remember that headache में balm लगाते हैं, so basically the sensory pathways get disrupted. The interneurons जो होता है या sensory perception जो होता है, वो inhibition pain pathways inhibit हो जाते हैं because of the pressure pathways being overwhelming the pain pathways. And this is what occurs in acupressure also. Acupressure भी इसी तरीके से pain relief करता है.
And our reading is that pain they travel the fastest. Dr. Khanna, please. Pain nerves, they travel the fastest. Pain or
Signals.
pain sensations, heart temperature sensation. They run the fastest as compared to pressure sensations.
I don't know.
There is an inhibitory effect of the pressure on the pain pathways. So this is the reason आपका जो pathways है जो preferential जो होता है वो pressure का होता है. So उसमें तभी आप pressure देते हैं या massage करते हैं, so that inhibits the pain pathways, so that conduction gets delayed.
I think the molecular mechanism is via the gate mechanism of the pain.
Gate
That's what
Ji,
happens
sir.
down the region and one cause.
जी sir.
Gate pathways.
Gate
Gate
pathways.
pathway, that is.
So, I think we should come to the end, and thank you, Dr. Shweta, and thank you, Dr. Rajiv, for wonderful discussion. I missed few questions, but next time we'll take those questions.
Thank you.
Thank you.
Thank you.